Okay, Dr. Yanin, please.
Good morning. Greetings from Bangkok Hospital and College of Medicine. I will be discussing our experience with radiographic healing of far cortical locking constructs in distal femur fractures. There are no disclosure pertaining to this research. All implants used in the study have been approved by the FDA. Distal femur fractures are often comminuted, treated with locking plate fixations, and depend on some degree of interfragmentary motions to stimulate osseous union. Far cortical locking screw constructs, or FCL, are designed to permit controlled interfragmentary motions which have been shown in animal models to increase callus formation to a greater extent than standard lock plating construct, or LPs. Previous studies have shown that FCL significantly reduce axial stiffness and provide flexible fixation and nearly parallel interfragmentary motions. So that brought us to our research questions. The primary purpose of the current study is to identify differences in radiographic healing of distal femur fracture treated with FCL compared to standard LP using the modified RCOST score as an outcome measure. We hypothesized that FCL would increase callus formations as compared to standard LP. After IRB approval, we conducted a retrospective comparative study, including 143 consecutive patients with 146 distal femur fracture, AO, OTA type B fractures, non-union cases, patients less than 16 years old, absent follow-up radiograph or follow-up less than 12 weeks were excluded from our study. After applying our exclusion and inclusion criteria, 96 fractures were included for analysis. 52 patients in the FCL groups and 42 in the LP groups. AP and lateral knee and femur radiographs were independently reviewed by 3 trauma fellowship-trained surgeons to evaluate callus formation using the modified RCOST score. Radiographs at 6, 12, 24 weeks and final follow-up when available were included. Basic demographic data were recorded for each patient. The modified RCOST score, or MRAS, is a tool used to evaluate bony union radiographically, with a score of 1 to 4 given to each cortex. 1 is no callus, 2 is callus present, 3 is between callus, 4 is remodel or fracture not visible. As you see the example X-ray on this slide, we give 4 and 4 for medial and lateral cortices, 3 and 4 for anterior and posterior cortices with a 15 of modified RCOST score in a scale of 4 to 16. Investigators were blinded with respect to the screw and plate constructs. This is our results. There were no significant differences between FCL and LP constructs in terms of demographic data. 53% of patients were periprosthetic fractures. There were no statistically significant difference between those constructs in terms of complications. Based on radiographic and clinical findings, the union rate was 92% in FCL and 88% in LP, which is no statistically significant difference. The non-union rate was 8% in FCL and 12% in LP, with no statistically significant difference. Statistically significant difference in modified RCOST score were noticed between FCL and LP groups at 6 weeks with p-value at 0.04 and 12 weeks with p-value at 0.04 also. However, there were no statistically significant differences at 24 weeks and final follow-up. Interclass correlations was moderate with agreement at 6, 12, 24 weeks and final follow-up. However, there are several limitations to the current study, examples being the retrospective design and variation in surgical techniques among surgeons. Additionally, we were unable to control the amount of soft tissue stripping at the time of injury, degree of comminutions, age, and general health status, or no to affect fracture healings. Furthermore, implant materials was not uniform with implants comprised of stainless steel and titanium. In addition, the stiffness of the constructs, working length, number of screws, or bridging distance were not defined in the studies. And another thing, as you see the example X-ray on this slide, even if there's more robust callus in the FCL group, We gave the same score as the small callus in the LP group. So the outcome measurement doesn't make a measurement callus volume or area directly. In conclusions, to our knowledge, this is the first comparative study between FCL and traditional LPs. The FCL group was noted to have low non-union rates, low fixation failure rates, and overall complication rate in short-term follow-up. The FCL group was noted to have significantly higher modified RUS score at 6 and 12-week time periods. So further prospective study design are warranted to clarify the law of interfragmentary motions on callus formation in fracture healing. Thank you for your time.
Now you can proceed to your next paper.
Greetings from Bangkok Hospital and College of Medicine again. I will continue with my study with sensitivity and specificity of modified RUS score using clinical and radiographic finding as gold standard. And also there are no disclosure pertaining to this research. Radiographic criteria of fractures healing includes many factors ranging from cortical continuities, visibility of a fracture line, specific number of bridging cortices, or simply surgeon impressions. One such scoring system is the Radiographic Union Scale for Tibia Fracture or RUS, which is a numerically evaluates and assesses progression to union after intramedullary nailing of tibia fractures with score of 4 to 12. The modified RUS score or MRUS was developed in order to assess progressions to union and to define a numerical value to fracture healing of metadiaphyseal fractures. The range of the score is between 4 and 16. So the purpose of this study is to evaluate sensitivity, specificity, accuracy, and cutoff point of the MRUS score in the evaluation of metadiaphyseal fracture healings, subsequently to determine optimal cut-off values of MRUS at various time points. Lastly, the study assessed clinical effectiveness of this score. After IRB approval, we conducted a retrospective study, including 146 sets of radiographs of distal femur fracture treated surgically, and also AOO type B fractures, non-union cases, especially less than 16-year-old, absent follow-up radiograph or follow-up less than 12 weeks were excluded from the study. After applying the exclusion criteria, 104 sets of radiographs of distal femur fracture were included in the study. AP lateral knee and femur radiographs were independently reviewed by 3 trauma fellowship-trained surgeons to evaluate callus formation using the modified RUS score. Radiographs at 6, 12, 24 weeks and final follow-up when available were included, and also basic demographic data were recorded for each patient. This is again, the MRUS score is to use to evaluate bony union radiographically in these studies, with score of 1 to 4 given to each cortex. 1 is no callus, 2 is callus present, 3 bridging callus, 4 is limb model or fracture not visible. As you see the X-ray example on this slide, we give 4 and 4 for medial and lateral cortices, 3 and 4 for anterior and posterior cortices, which is a 15 of modified RUS score on a scale of 4 to 16. This is our results. When the MRUS score was assessed as a predictive of healing at 6 and 12-week time points, the optimal cut points were 7 and 9 respectively. At these earlier time points, the sensitivity and specificity were 52% and 59%, 79% and 81% at 6 and 12 weeks respectively. The accuracy of 6-week time points was 53%, with positive predictive value was 34% and negative predictive value was 89%. However, the area under the curves, as you see the picture above, was 55-93, which is classified as not good according to classification system of area under the curve. The accuracy of 12-week time points was 79%, with positive predictive value was 98% and negative predictive value was 42%. The area under the curves at the same cut point was 0.8864. Let's see the MRAS score at 24-week time points. The optimal cut point was 10. At this time point, the most appropriate sensitivity and specificity of the MRAS obtained were 92% and 100% respectively. Using the same cut points, positive predictive value was 100% and negative predictive value was 54%, with the highest accuracy of 93%. When we increased the cutoff point to 13, yielded decreased sensitivity to 42%, but increased specificity to 100%. The area under the curves was 0.9826, which was classified as an excellent. Interclass correlations was moderate, with agreement in this study at 6, 12, 24 weeks. There are several limitations to the current studies. The erosion of the lateral cortex in the fracture treated with lateral plate constructs can be very difficult, as the cortex can be obscured by the implants. And also the ICC for plate constructs demonstrated only moderate disagreement in the studies. And over time, patients losing to follow-up. So we leave smaller groups of patients as subsequent follow-up. Most notable is potential variations in subjective evaluation of healings between physicians at follow-up. This, however, in our opinion, reflects accurately the practice occurring in routine clinic visits, therefore stand as a satisfactory bank of information. Lastly, with the low prevalence of non-union, probably 12% in this study, the diagnosis of non-unions in the population may result in low accuracy, as accuracy is influenced by the prevalence of the disease in a selected population. In conclusion, this is the first study to evaluate sensitivity, specificity, accuracy, and cutoff points of the MRAS score. Our results demonstrated good to excellent accuracy ranges in assessing metadiaphyseal femur fracture healings. The MRAS score obtained at 24 weeks follow-up yield the highest sensitivity and specificity of 92% and 100% respectively, with the highest accuracy of the MRAS score was 93%. So the MRAS score at least 10 must be used to rule out non-unions. However, this significantly reduces sensitivity. The area under the ROC curve linked from good to excellent at 12, 24 weeks and final follow-up. The MRAS performed poorly in early post-operative periods, which is less than or equal 6 weeks, and should not be used to reliability assess or predict ultimate body unions in this time period. Thank you for your time.